Welcome to the deep dive. We've got some really relevant information you sent over, all focusing on heart health.
Yeah, specifically looking at cholesterol, right? The bad kind.
Exactly.
Yeah.
So our mission today, based on this research you shared, is really to nail down the most effective way to lower that LDL cholesterol.
Especially for people already at high risk, you know?
Right. We want to see what the science actually says is the best initial approach.
And the main source here, it's this really significant new meta-analysis just out in the Mayo Clinic Proceedings.
Okay.
And the scale is, well, it's huge. It's the biggest study like this so far.
How big are we talking?
They pooled data from 14 different clinical trials, over 108,000 high-risk patients.
Wow, 108,000. So these are people who've maybe already had issues?
Exactly. Prior heart attack, stroke, or just generally a very high chance of having one based on their health profile.
Got it. So with all that data, the core question we're tackling for you listening is basically this. If someone's high risk, is it better to start them right off with a combination, a statin plus this other drug, Ezetimibe?
Or just stick with the usual approach, maybe a high dose of a statin first.
Right, because we're talking about strategies that could genuinely prevent, really serious events. Heart attacks, strokes.
Cardiovascular deaths even, stuff that matters hugely to individuals and their families.
Absolutely.
And while the headline finding from this huge analysis is pretty striking, it could really change things.
Okay.
The researchers found that for these high-risk patients, the ones with already blocked arteries, starting treatment with both drugs, the statin and ezetimibe, right away, it was significantly more effective than just starting with statins alone.
Significantly. How much difference are we talking?
Well, the potential impact they mentioned is preventing thousands of deaths every year.
Thousands. Wow. Okay, let's break that down. What were the specific benefits they saw comparing the combo to just high-dose statins?
Sure. The numbers are quite impressive. They saw a 19% reduction in all-cause mortality.
So fewer deaths from any cause.
Exactly. Then specifically for cardiovascular deaths, heart-related ones, a 16% reduction.
Okay.
Major cardiovascular events, that's things like heart attacks, strokes, needing procedures like stents, that was down 18%.
18%.
And strokes on their own saw a 17% reduction.
Those are really substantial drops. It's not just marginal, is it?
Not at all. It suggests, a real chance at more years of healthy life avoiding these major health crises.
Right. It's about lives saved and major events avoided, not just numbers on a lab report.
Precisely.
Now, you mentioned the combination also did better on cholesterol control itself. How much lower did the LDL go?
Yeah, that's key, obviously. The combo therapy lowered LDL-C, the bad cholesterol, by an additional 13 milligrams per deciliter compared to the statins alone.
Okay, 13 milli-GDL more. Does that make a big difference in practice?
Well, here's where it gets really interesting. That extra drop meant patients on the combination were 85% more likely to actually hit that target LDL level.
85% more likely.
Yeah. To get below 70 milli-GDL, which is the goal for these really high-risk folks, hitting that target consistently is what gives the long-term protection.
That really drives home the point, doesn't it? Hitting it from two sides, liver production and gut absorption, makes a huge difference.
It seems so.
Now, the study used something called a network meta-analysis. Sounds complex. Can you simplify what that means and why it adds weight?
Yeah, it's a bit more advanced than a standard meta-analysis. Think of it like this. A regular one directly compares studies looking at, say, treatment A versus treatment B.
Okay.
A network analysis lets you compare multiple treatments, even if they weren't directly tested against each other in the same trial. It uses a network of comparisons, including indirect ones, maybe A versus placebo and B versus placebo, to figure out how A compares to B.
Ah, I see. So it pulls in more data, more comparisons.
Exactly. It gives a broader picture. And what's fascinating here is that this network analysis showed even stronger results for the combination.
Really? Stronger than the main findings?
Yeah. Compared to high-dose statins alone, the network analysis pointed to a 49% reduction in all-cause mortality.
49%, almost half.
Almost half. And a 39% reduction in major adverse cardiovascular events. Those are really, really significant figures. Adds a lot of confidence.
Absolutely staggering numbers. Okay, but adding another drug always raises questions about side effects, tolerability. How did the combination fare on safety?
That's a crucial point, of course. And the good news here is that the study found the combination was, well, safe and generally well tolerated.
Okay.
The rates of adverse events, side effects, and also the rates of people stopping the medication, they were pretty much comparable between the combo group and the statin-only group.
So no major red flags on safety.
Doesn't seem so. In fact, that network meta-analysis we just talked about, it actually showed a 44% lower risk of people stopping treatment if they were on a moderate dose statin plus ezetimibe compared to a high dose statin alone.
Oh, that's interesting. So maybe the combo allows for a slightly less intense statin dose, making it easier to stick with.
That seems to be the implication. Better adherence is key for long-term benefits, so that's quite important.
Definitely reassuring for anyone listening who might worry about adding meds.
Yeah.
So this research, it really sounds like it could shake up how doctors approach this, doesn't it? Does it challenge current guidelines?
I think it definitely raises questions. You know, the standard practice often is start high-risk patient on high-dose statin, check levels, then maybe add ezetimibe if needed.
Right, step by step.
But this evidence, it's pretty robust, suggesting that for the really high-risk people, especially right after, say, a heart attack, maybe starting with the combination right away is the better move.
So flipping the usual script.
Potentially. One of the authors, Professor Peter Topf, actually said that for these very high-risk patients post-event, the combination should maybe be considered the gold standard for initial treatment.
Gold standard. That's strong language.
Yeah.
So remind us again, why is this combo so effective? What's the mechanism?
It's really about hitting cholesterol from two different angles, like we touched on. Statins mainly cut down how much cholesterol your liver makes.
Okay.
Ezetimibe works down in the intestines. It limits how much cholesterol gets absorbed from your food.
So less production, less absorption. Makes sense.
Exactly. A two-pronged attack. And it's worth remembering, too, that statins themselves have different strengths, right? High intensity, moderate intensity.
Yeah.
And this study suggests maybe a moderate intensity statin plus ezetimibe could be more effective and maybe better tolerated than pushing a high-intensity statin alone.
That's a really key insight. Better results potentially with fewer side effects.
Potentially, yeah.
Now, the authors also talked about the global picture. High cholesterol is a huge problem worldwide, isn't it?
Oh, absolutely massive. The study cited some pretty sobering figures. Like, in 2020, an estimated 4.5 million deaths globally were linked to high LDL-C.
4.5 million.
Yeah.
Yeah.
And the burden isn't spread evenly. Places like Eastern Europe, Central Asia, they have some of the highest death rates linked to this.
Just staggering numbers. And Professor Banach, another author, made some projections about lives that could be saved if this combo approach was used more.
Yes, his estimates were really significant. He suggested that if guidelines changed and doctors started using this combo therapy more widely for high-risk patients, we could potentially prevent over 330,000 deaths globally each year, just among people who've already had a heart attack.
Over 330,000 a year.
And just in the U.S. alone, the estimate was around 50,000 preventable deaths annually.
Incredible potential impact.
Truly.
And another important point Professor Toth made, I think, was about cost. This isn't some brand new, super expensive drug, is it?
Exactly right. He stressed that. We're talking about using existing, well-known medications more effectively.
So potentially more accessible.
Yes, and potentially even cost-saving in the long run. If you prevent more heart attacks, strokes, hospitalizations for heart failure, those things are incredibly expensive to treat.
Right. So better health outcomes and potentially lower healthcare costs. That's the ideal scenario.
It really is a win-win.
The study also seemed to boil things down to a couple of key sort of guiding principles for treating these patients. What were those again?
Yeah, Professor Toth mentioned two simple but powerful ideas. First, the lower the better for longer for LDL cholesterol.
Keep it low, keep it sustained.
Exactly. Long-term control is crucial. And second, the earlier the better for starting effective treatment in high-risk people.
Makes sense. Don't wait.
And this research really backs that up. Start with the most effective strategy right away to get those levels down sooner and keep them there.
Okay. Now, with any big study like this, it's good practice to look at strengths and weaknesses. What did the researchers themselves point out?
Well, the huge strength, obviously, is the size. All that data, over 108,000 patients across 14 studies. That's the biggest analysis we have on this.
Right, gives it a lot of weight.
Definitely. But they were also upfront about limitations. Like, most studies included were top-tier randomized controlled trials, 11 of them, but 3 were cohort studies. Those are observational, so they show links, associations, but can't prove cause and effect quite as strongly as an RCT.
Got it. So mostly strong evidence, but a mix of study types.
Yeah. And they also noted, the individual studies varied a bit in size and design, which is pretty typical for a meta-analysis. You're pooling different pieces of research.
Okay, so keep those nuances in mind. But the overall picture seems pretty clear from the sheer amount of data.
Exactly. Look at the whole picture, strengths and caveats together.
So bringing this all together then, for everyone listening who sent in these sources, after this deep dive, what's the main takeaway message?
I think the clearest message is this. The evidence we have now, especially from this huge analysis, strongly suggests that if you're at high risk for heart attack or stroke,
Yeah.
starting treatment right away with both a statin and ezetimibe seems significantly better than just starting with a statin alone.
Better for lowering the bad cholesterol.
Yes, and crucially, better for actually reducing the risk of serious events, like heart attacks, strokes, and even dying from cardiovascular causes.
And as we've discussed, the potential impact is huge, not just for individuals, but globally, possibly saving hundreds of thousands of lives if treatment approaches adapt.
Absolutely. It really shows the value of looking hard at the treatments we already have and figuring out the smartest ways to use them.
So, a final thought for you, our listener. Thinking about this new evidence, what questions does it spark for you about your own cholesterol management or maybe for loved ones at risk?
It's definitely valuable information to bring up and discuss with your doctor, wouldn't you say?
Absolutely. Something important to consider in your next conversation with your healthcare provider.